shows the initial source of advice or treatment for a child under 5 that has fever. We've got 4 countries here, and the initial source is described either as at home, so that's talking with family or friends and perhaps using traditional remedies or antipyretics such as Panadol. And then going to the private sector is in green and the public sector again is in blue. So as you can see, the majority of countries, all the countries here in fact, are just seeking advice at home first, which is worrying in the case of delay of getting appropriate treatment. And then, if they're not doing that, they're actually generally going to the private sector more than the public sector. So one more slide about this, broken down Madagascar and Nigeria. Again, it shows that of the proportion who are, this is actually the source of the antimalarials, so where they're actually getting the antimalarials from, and we can see that that's the at-home component here is the source of them. So for Madagascar, is about half of them are got from, just over half are got from the private sector, and in Nigeria, it's almost 3/4 of those antimalarials that were at home were actually got from the private sector. So emphasising, we know Nigeria particularly, the private sector is the source. So just some other pieces of data. This is a 27-country survey of population-rated DHS data, and this was treatment-seeking sources for fever, cough, and diarrhea. And this shows that about half of these countries were seeking help in the public sector, and about half in the private sector. That's a paper from Montague. And finally, just recently, Hodgkin has presented a paper, and that's also again looking at fever treatment as well as cough and diarrhea. So I've just got the results here for fever seeking. And that showed again that in 6 out of 10 Central West African countries that the private sector was the main source. Liberia clinicians, DRC shops and private clinicians were very important. And Benin, Guinea, Nigeria, private shops predominated. And then the East and Southern Africa, the public sector accounted for the largest proportion of cases, except for Uganda, and also Kenya and Tanzania, where drug shops are very important. So that's it really. So just in conclusion, the private sector is very important, but the private sector has got a lot of bad stuff in it. If we can improve the quality both of the drugs and of the case management, then we will be having impact on the severe childhood illnesses. Thank you very much.
Let me borrow this one. Thank you very much, Jane. And unfortunately, we don't get his visa on time, so we're delighted that Dr. Karen Woltersberger will actually present on his behalf. So Karen, take it away, please.
Thank you. I'm not a doctor, but I'm a public health anthropologist, and thank you. And I work for Save the Children US, and I'm a senior regional health advisor in Africa. So I'm presenting this for Bangladesh, so show me a little mercy. But I'll do the best I can. And actually, I was familiar with this paper when it was first written, and Save the Children has a lot of experience in various African countries working with public sector, so I was happy to be able to help out get this paper. So it's called Village Doctors Engagement, CCM, and it's the Bangladesh experience. So we were just talking about malaria, but malaria, of course, is not a huge problem in Bangladesh. But here we're talking about pneumonia treatment pneumonia treatment status in Bangladesh. That 35% of children with symptoms of pneumonia, that's a third of all children, with symptoms of pneumonia were taken to health facilities or a medically trained provider, and that means that 2/3 were taken elsewhere. Half of those care seeking for pneumonia went to drugstores and village doctors, and almost 80% of the children seeking a provider were prescribed antibiotics. But again, it's a question of which antibiotic. So, Save the Children works with, in 17 sub-districts in the southern coastal part of Bangladesh, and working with the district authorities and with the Ministry of Health authorities. We're reporting on a project that looked at community case management of pneumonia and diarrhea in these 17 sub-districts. The target group were children under 5 years old, and there were about 400,000 of them in this area. And the period being reported on was February 2012 to April 2014. Procter & Gamble was our donor. So it was a two-pronged approach, looking at increasing quality, access to quality services. So on the one hand, we were working with MOH, frontline workers, and strengthening capacity in health facilities. And the other side was capacity building of village doctors and then linking them to the formal services. And there was also a community engagement and support mechanism. So what is the rationale for engaging the village doctors? First of all, most village doctors, they either inherit their drugstores from other family members, in which case they might do a kind of apprenticeship or learn on the job. Some of them, most of them have secondary level training, but, and then they get a 3 to 6 months training. 6 weeks, I'm sorry, I'll have to check that. But in rural, as a rural medical practitioner, and then others have maybe been trained as pharmacy technicians, or there's another category working with family planning. So most of them come to have their drugstores in this way. So by engaging village doctors, we hope to increase access to case management for children living in remote communities. Since most of the village doctors run their drugstores in remote communities in rural areas. And to improve the quality of pneumonia and diarrhea case management, the village doctors are there 24 hours a day, 7 days a week. And I think those of us working in CCM know that, that's really one of the requirements, is that you have to have the services available 24 hours a day, 7 days a week. They're a very popular choice among the population. They provide drugs, for example, on easy installment payments. So therefore it becomes more financially accessible. They always have drugs available somehow, at least in Bangladesh. And they also will make home visits. They'll come to your house, so if you call them. So the project activities were first of all to revise the village doctor training manual in partnership with the IMCI unit of the Ministry of Health. And then to adapt the monitoring and supervisory tools. There were nearly 300 village doctors trained for 3 days on CCM of pneumonia and diarrhea, 281 currently active. They were provided with essential job aids like timers and chart books and treatment registers, and with supportive supervision, and that was joint supervision by ministry personnel as well as project staff. There were post-training follow-up visits that each village doctor was supervised twice a month during the initial 3-month period, and then after that they got monthly visits. The registers were reviewed, there was direct observation, and if there weren't any children to observe directly, they used case scenarios. And then random household visits where children had been treated to look to see if there was satisfaction. I'm sorry, am I not speaking into the microphone? bi-monthly performance review meetings, and yearly refresher training, one-day refresher trainings. So, if you look, you can actually see that a large proportion of the cases treated were pneumonia cases. There was also diarrhea, cough and cold, and a very small proportion were referred. But it's important because in the past, the village doctors didn't do much referral of severe illness. The service quality results, I think, are pretty impressive, that except for record keeping, which was a little bit below 90%, they were pretty much all at around 90% on correct case management according to treatment protocol, consistency, availability of supplies, availability of drugs. So the major findings from the village doctor assessment was, first of all, that the village doctors wanted to join because it was a skill development opportunity for them. It showed their social commitment, which I think they do feel, and that it's a way to increase patient flow and potential business expansion. There was a 92.5% retention rate, and interesting reasons for dropout. One, that they experienced a low number of pneumonia cases. There was a big burden of work with maintenance of protocols, a low profit margin because they were encouraged to use amoxicillin, and earlier they had used other third generation antibiotics that were more expensive and actually showed a faster recovery. And the patients and families wanted to see that faster recovery. And then migration. So just before and after, before the training, only 35% used equipment for pneumonia diagnosis. They made their diagnosis based on symptoms. They used those third generation antibiotics. After the training, they were using their ARI timers to count respirations. They were using amoxicillin and referring severe pneumonia cases, and that's very important. And before the training, their attitudes and practices around referral was they didn't really give referrals because they thought that would impair their credibility. And they didn't want to send people elsewhere because they would lose their profits. So after training, they were giving preference to the treatment protocol over the business motive and referring sick children by using criteria rather than just trial and error. And so the lessons learned were that the diversity of participants' experience, existing knowledge, and education made the training challenging. So in other words, they didn't all come with the same backgrounds. As I said, some of them inherited, some had in-service training, some had different kinds of training backgrounds. That the low profit margin and slow recovery of treated cases with amoxicillin were reasons, or barriers for following the standard treatment. And again, the joint supervision and linkage with the health facility were very important. And that's all.
So, in Uganda also, drug shops are an important source of care, and 50-60% of children actually seek care at drug shops when they are ill. Most of the private sector is comprised of drug shops. In the district I was at, there was almost no private clinic. Everything else was drug shops, registered and unregistered. But the problem with drug shops, as we've already seen, is that in most places they are unregulated. We have registered drug shops where the National Drug Authority is interested in basically structural arrangement, and they get licensed because they have a good facility that can store medicines properly. But beyond that, what the drug sellers are actually treating, nobody cares. Nobody knows. Quality of care is poorly documented in this group. but it's also known to be poor. Drug use is also not rational because of mainly profit motivation. Given that background, we set out to determine how feasible and effective and integrated community case management malaria, pneumonia, and diarrhea program would be if introduced within drug shops. And we use registered drug shops in Eastern Uganda. We used a quasi-experimental design and took an intervention district and a comparison, each with around 300 to 400,000 population. And we took all the registered drug shops in both of these areas, and they amounted to about 40 and 44 and 40 respectively. So in the intervention area, we implemented iCCM. Provided access to the drug sellers to subsidized, highly subsidized drugs and commodities. Drugs, so the antihistamine combination therapy, which was from Global Fund's Affordable Medicine for Malaria program, and dispersible amoxicillin tablets or rehydration salts and zinc as recommended, and all dispersible and packaged for a single dose for a child. We provided a diagnostics free of charge to drug sellers, as this was a feasibility study. So both the rapid diagnostic tests and the respiratory timers that were used were free of charge. And we provided the iCCM training adopted for drug sellers, which it was for 5 days, daily clinical sessions in a health center, and the drug sellers were trained to identify danger signs in children that must be referred, chest drawing, people with convulsions, and all that. They were also trained to utilize the malaria rapid diagnostic tests and the respiratory time to diagnose malaria pneumonia. And that was the standard, intensive training for community health workers. And then we had a social marketing strategy as well, where involving our community, a community awareness, and this was all done by a case in Uganda, which is PSI. And this also involved labeling of the drug shops, labeling of the medicines, and even the community was aware of exactly what they could get, what diagnostics for what, even at what price. We went to that detail, so that to basically make people have a really aware consumer. In the intervention, in the comparison area, just before we started the study, the Medicines for Malaria Venture was working in this districts and trained both the intervention and control area on management of malaria with artemisinin combination therapy, and there was also a community awareness campaign on referrals to children and what to do. So also in the control district, but that was done by a different group just before we started the intervention. And the actual program was for over about 1.5 years, but the data collection over 10 months difference. 2011 and 2012, and we looked at baseline and end-line assessment with